So Shakira is a research assistant in implementation science in our cancer and primary care group, and also as part of the Department of General Practice. She has a strong interest in cancer prevention through guideline implementation and helping patients to make informed choices. She's been working in our cancer and primary care group now for the last 4 years and is about to commence her PhD shortly. So Shakira, welcome. You're going to be presenting around the work on implementing aspirin guidelines to prevent bowel cancer. So over to you, Shakira.
Good morning, everyone. So today I'll be talking about the iMagic program, which stands for Implementing Aspirin Guidelines into Clinical Care, and it's a qualitative project. First, I'd like to say thank you all for being here, and John, thank you as well for your presentation, for your introduction. This project was supported by PC4, which is the Primary Care Collaborative Cancer Clinical Trials Group, and they were great to work with, and it was funded by the VCCC, or the Victorian Comprehensive Cancer Center. And the iMagic team is made up of the researchers listed there, and without my team, this research wouldn't have been possible. They were fantastic to work with, and also thank you as well to Carmody from PC4, who helped with a lot of the graphics, including this PowerPoint presentation, and thank you as well to my family and friends for supporting me through my work. So today I'll be covering the introduction and background all the way down to the results and talking about 2 focus groups that I ran, and then I'll talk about what's next after the iMagic program. So colorectal cancer is the 3rd most commonly diagnosed cancer in Australia. 1 in 12 men and 1 in 17 women will develop it by the age of 85. Colorectal cancer is also the 2nd cause, only to breast cancer, of cancer death in Australia. So there have been several meta-analyses of randomized controlled trials which show that aspirin reduces the incidence of colorectal cancer by 25%. It also reduces mortality or death of colorectal cancer by 33%. And these are huge figures. So in response to this research, the Cancer Council Australia released guidelines in late 2017, which recommend actively considering aspirin to prevent colorectal cancer. And this is a world first for the average risk population. So average risk means that everyone should be taking aspirin to prevent colorectal cancer. The release of these guidelines, there was no implementation strategy. So as with most guidelines, they rely upon just passive diffusion. So we thought about this question to further implement the guidelines into clinical care. So the question is, what are clinicians' practices, knowledge, opinions, and barriers and facilitators to implementation of the guidelines? And we approached this research with these 2 questions. So first, what are clinicians' practice, knowledge, opinions, and barriers and facilitators to prescribing aspirin to reduce the risk of developing colorectal cancer? And then the second question was, what are their views and feedback on the new risk communication graphics called expected frequency trees, or EFTs, and I'll walk you all through what these are, and we'll have a look at some of them. So the recommendations for aspirin chemo prevention state that for all people who are at average risk, so that's most of the population, some people are at an increased risk of colorectal cancer, but for all people who are at average risk, aspirin should be actively considered to prevent colorectal cancer. So it's a low dose of aspirin, and there's a range of 100 to 300 milligrams per day. If you have a headache, you would take about 600 milligrams per day, so it's a lot less than that normal dose. And then it's recommended that patients take it for at least 2.5 years, and they should commence taking it from the ages of 50 to 70. So these recommendations also should be personalized and based on a person's age, sex, and a potential reduction in cardiovascular events, cerebral vascular events, and thrombotic stroke. The individual should also take into account the potential risk of taking aspirin because they aren't without them, and we'll cover some of those as well later. So to conduct this program, we use the Consolidated Framework for Implementation Research, or CFIR, to underpin our interview schedule or the questions we ask the different clinicians. So CFIR is an online suite of different constructs and everything that could potentially affect effective implementation of any intervention. So it's very comprehensive, and we thought it was the best tool to use to help guide this study. And then we went on to conduct semi-structured interviews with clinicians to whom the new guidelines may be applicable. And the interviews were then transcribed, inductively encoded using in vivo 12, and qualitatively analyzed using thematic analysis. So the patients are at the center of all of what we do. And so the clinicians we thought the guidelines would be applicable for were general practitioners. So I interviewed 16 of them. We had an honor student who interviewed 14 pharmacists, and then I went on to interview 10 genetic counselors, 7 geneticists and oncologists, and then we had another medical degree research program student named Vivi who interviewed 17 gastroenterologists. So the interviews lasted from 20 to 50 minutes, and we interviewed a total of 64 clinicians. So it's quite a large group of clinicians were interviewed. And we asked their feedback on the guidelines. We asked what they thought about them, and really focused on exploring their practices, knowledge, opinions, barriers, and facilitators regarding the guidelines. So one oncologist said, it doesn't hurt for me to do it. Most of these things are probably more general practice. We tend to defer to the GP to manage all those sort of things. So they thought, yeah, we can mention it to patients, but it's probably not our role. And the same with the genetic counselor. And this genetic counselor said, we can raise the topic and talk about that there are recommendations, but it's not necessarily our area of expertise. And then, to our surprise, one of the general practitioners said, I don't think many GPs are aware of the latest guidelines for things like the use of low-dose aspirin. Those sort of things I've certainly not heard of before. And this was common with most of the GPs who were interviewed. They just weren't aware of the guidelines. They received so much information, and new guidelines are published every year. And without an implementation strategy, it's not surprising that they didn't know about it. And then a gastroenterologist said, so I see more of a role for it in primary care. It should be happening before they come to see me. So gastroenterologists didn't really think it was their role to implement the guidelines. And this quote is probably one of my favorite quotes out of the whole project. And it really, centers in on what we should be focusing on. But a general practitioner said, general practice is probably in the best position to do this because we're really good at this, because we're looking at the whole person rather than just one specific system. And we do a lot of preventative health. That is the bread and butter of what we do. So this really helped us to focus in on general practice. So these are the expected frequency trees. So we have one for men and one for women. And I'll do a lot of back and forth clicking, but it's just to show you what's being presented. And then I have these before ones, and then after we received feedback, we updated them, and I'll show you those as well. So the caption says, expected frequency trees showing the effects of aspirin on the incidence of events over 10 years of taking aspirin for at least 5 years in Australian men aged 50 to 70. So just starting here at the top, if 10,000 men took aspirin or didn't, so if they didn't take aspirin and they took aspirin, these are the events that would happen. So if they didn't take aspirin, there'll be 178 cases of bowel cancer. And if they did, there will be 134. And then with heart attack, we can see a decrease, stroke, a decrease, and then a slight increase, which is, the risk of taking aspirin, which is bleeding from the stomach and gut. And the same with the women. There's a decrease in bowel cancer, heart attack, stroke, and then a slight increase in bleeding from the stomach and gut. So these are the new ones that which incorporated all of the feedback or most of the feedback we received from the different clinicians. And I'll do a little bit of back and forth between the old one and the new one. So we asked them what would make these expected frequency trees easier to understand. Would you actually use them with your patients? Do you think that they're beneficial? What would you like to change on them? And I guess the first major thing that changed was adding in mortality or death from all causes, which you can see. We originally also thought that we didn't want to have too many numbers on it. We didn't want to make it too complicated, but most of the clinicians found that they were doing the math. So they requested that we add in the difference line, and we did. So it's easier to just quickly look at the difference between no aspirin and aspirin. So they also wanted to get rid of the male and female icons and the little pill bottles, because they just thought, what's the point in having them there? So we took those off, and then we added in arrows so it's easier to differentiate. And then another thing that we changed was the color of the risk, because before it was all the same, and they just said it didn't really stand out as a risk before, so we changed that as well. And the same thing for the women, and the caption also changed a little bit, and we added in mortality, and we had some grammatical errors that they pointed out, like commas and things like that. But so what did the clinicians think of these expected frequency trees? A general practitioner said, I think pictograms are very good for patients who often have difficulty of grasping concepts. And a gastroenterologist said, yes, I think that's a very clear and easy to understand flow chart there. I think most people would get that. And then a genetic counselor said, something like this would be really helpful. Particularly, a lot of patients that I see can comprehend this with just having a little chat. But complex medical information shown in this diagram show the benefits clearly, and it's really helpful. And a genetic counselor said, it's a good way of presenting it. It depends on how numerate people are. And we've certainly had a lot of experience with patient-facing materials like this. Some people like their pictograms of the number of people affected by different things. Other people prefer it in graphs and other things like that. So I don't know if there's one way, but that certainly puts across the risks and benefits quite well. So overwhelmingly, they were in support of using the EFT. And in response to these clinicians' feedback, we thought we'd implement or use the EFTs with a decision aid. And I conducted 2 focus groups to gain feedback from consumers or people from the general public on the EFTs, which were incorporated into 2 decision aids for men and women. And a decision aid can sometimes be electronic, but in this case, we used paper brochures. And I just went back to my computer and just designed something very quickly on using Word. And then we had Carolyn, who was working with us at the time, redesign them from my sort of very basic version. So the decision aid before consumer feedback looked like this. And as you can see, taking aspirin to reduce your risk of bowel cancer and information to support your decision. And then once you opened it up, it looked like this. So you see the EFT is there. We changed the colors a bit so that it matched the theme of this brochure. And then in those focus groups, I asked different clinicians or different consumers, so people from the general public, what they thought about them and if it was easy to understand, if there's anything they thought should change. And so after the consumer feedback, this is how they looked. So they changed them dramatically. They thought we should move the text up to the top, because if these brochures or these decision aids are used or are in the waiting room of a general practice, they wanted them to stand out right away and be easily seen by the necessary people or the people they should be used for. So we added in, are you a man between the ages of 50 to 70 on the front, and then made that big and bold. And this is the one for the women. And then once you open it up, it looked like this. So the expected frequency tree changed as well, quite dramatically, but it looks really easy to understand. It's the text is a lot bigger than what we had before so that people can read it without their glasses. And we added in and changed the color so the contrast was a lot stronger. And then this is how it would look if it were standing up. So aspirin can reduce your risk of bowel cancer by up to 25%. And then we have the Cancer Council guidelines there. And we did ask them for their permission to use their logo, and they were happy to support this because they released the guidelines. So in conclusion, the aspirin guidelines should be implemented in general practice. The expected frequency trees are useful, but should be talked through with a clinician and may not be for everyone. We decided to get consumer feedback on the expected frequency trees, incorporated into decision aids through conducting the 2 focus groups. And as a result of this project, I'll be conducting a randomized control trial, which will make up my PhD to further implement the guidelines into general practice using the decision aids. And I'll have a quick overview of this project as well. So in late last year, so in December, right before the break, we received a phone call from the Victorian Cancer Agency, and we were awarded a grant, which was fantastic because it supports the CETA trial, and CETA stands for Should I Take Aspirin? So the aspirin, the Should I Take Aspirin trial, and it's a randomized control trial of a decision aid to support informed choices about taking aspirin to prevent cancer and other chronic disease. So what I'll do with this project is recruit 238 patients aged 50 to 70 from 4 to 5 general practices who aren't currently taking aspirin. So within the general practice waiting room, we'll have a research assistant out in the waiting room approaching patients, and I'll be in one of the consulting rooms. This will all take place before they go and see their GP. So we have the intervention group who will get that decision aid, and I'll walk them through and talk them through it. They'll also receive a brochure about how to reduce your bowel cancer risk. So it's a Cut Your Bowel Cancer Risk brochure, and it's modified from the Cancer Council Victoria brochure. They'll also get their bowel cancer risk and cardiovascular disease risk, and the control group will only get that Reduce Your Bowel Cancer Risk brochure. It does have a lot of different tips and a lot of different things people can do to reduce their bowel cancer risk, including aspirin, but aspirin isn't specifically highlighted in there like it is in the decision aid. And the decision aid is there to help patients make an informed choice about taking aspirin. So after they participate in the trial, they'll go on to their GP visit, and then we'll follow everyone up after a month, and we'll see if they made an informed choice, if they made the choice to take aspirin, and if there was any decisional conflict. So if they thought making the decision was hard, and then we'll ask them about their discussion with their GP. So if they talked about the trial with their GP, if they discussed aspirin with their GP. And then we'll follow them up finally after 6 months, and we'll ask them about their aspirin use, any side effects they experienced, and then if they stopped taking it, what the reasons were behind their decision to stop taking aspirin. So that is my PhD, and thank you all for your time and for being present. Any questions?
First question for you, Shakira, is are you differentiating or advocating enteric-coated aspirin to reduce GI complications?
We aren't advocating or recommending enteric-coated aspirin specifically because the evidence isn't as strong, but we do know that there is some evidence, but yeah, we're not specifically asking patients to take enteric-coated aspirin.
So this is from Alex. How do you deal with the risk of complications? Many gastroenterologists would be concerned.
Because they're just coming to me and talking about whether or not they should take aspirin, all of their risk and complications will be referred on to their GP. So because I'm not a clinician, it's important that I'm not offering any medical advice in that area. Is that what you were asking? I think so. But yeah, so yeah, if they do present with any complications, we will refer them on to their GP.
And then Finn is asking about the endpoint in the CETA trial.
The endpoint in the CETA trial?
Yeah.
Oh, with the 2 years, are you asking? Because the grant funding goes for 2 years?
So what's what's the primary outcome, Shakira?
Oh, the primary outcome is whether or not patients made an informed choice to take aspirin, but we do have other outcomes, which is the decisional conflict. So how easy it was to make the decisions to take it, if they did make that decision. We do have others, as well as stopping taking aspirin and reasons for stopping, but the primary outcome is making an informed choice.
Thanks. And then a question around the issues of people with comorbidities on other medicines, and are there groups that aspirin will not be suitable for?
Yeah, so there are groups, people who are already taking other NSAIDs, so any other blood thinners for other purposes will be excluded from the trial. And then people who have a history of stomach ulcers and also complications in the past of different stomach or gastrointestinal issues, they will all be excluded from the beginning. But if a person does come up with, a lot of times they don't find out whether or not they have these complications until after they start taking aspirin, and the risks of taking aspirin present fairly quickly. So we'll know early on if someone's taking it and they shouldn't be, and it's not really detrimental to the person's health. I mean, in some cases it is, but not really. But we will be heavily involved with their general practitioner, and hopefully I answered your question.
Okay, and then a question that often comes up is around the Aspirin trial results, Shakira, and I do want to talk about the Aspirin trial.
Yeah, so the Aspirin trial was in a randomized controlled trial in very elderly patients, so patients over 70 years old, and you had an intervention group who took aspirin and then a control group who didn't take aspirin, and then they compared their events over 10 years, I think. No, it was a shorter follow-up, actually. It wasn't a long follow-up. I think it was like 4.7 years, actually, specifically. So the Aspirin trial showed that it wasn't very beneficial for the elderly population to take aspirin. And because these guidelines are for people who are 50 to 70, it's not directly linked, or it doesn't really cross with that same population. And when recommending aspirin, a clinician should also take into consideration a person's lifespan or expected lifespan, or so the Aspirin trial came up with the clinicians quite a bit, but there was some confusion around which cohort they were supposed to be used for. But in this case, we are talking about a bit of a younger population.
I'm not sure, around Jenny, whether this is follow-up in the CETA trial or in the context of Aspirin, but I presume it's in the CETA trial.
Oh, how long is the follow-up?
Mm.
So we just have that 6 months follow-up. So the 1 month, we'll follow them up with a questionnaire, and then after 6 months, we'll have a follow-up. And then that will be the end of the study for the participants. Yeah. And because it is a PhD, I do want to get, I want to finish it. So don't want to have too long follow-ups. Yeah.
But you will be looking at people who have started and stopped aspirin, as well as people who've started and continue to take aspirin 6 months after the intervention.
Yeah.
Okay, look, I think for the sake of time, we might just wrap up. Thank you very much, Shakira. Great presentation. Thank you for all the questions as well.